بسم الله الرحمن الرحيم، وخير ما نبدأ به بعد الصلاة والسلام على رسول الأمين وصحبه الكرام. Uh, it is my pleasure on behalf of Oman Society of Nephrology and Transplantation to invite all of you to attend this regular meeting and regular lectures, which will be, inshallah, about one of the important cardiovascular complications which happened frequently or infrequently during hemodialysis to our clients. It is my pleasure to introduce the speaker. I know him very well, Dr. Alaa, very well. He is my neighbor. Just we are separated by the borders. Every time they are sending his patient through air ambulance, we are receiving them for a lot of issues. Dr. Alaa is at Nofal. He is head of renal medicine at unit at Khasab. He is living in Oman since long time, alhamdulillah, I knew him very well. Today, Dr. Alaa, he will introduce this important topic, which highlights the major cardiovascular complication which happened routinely during dialysis. Hence, I invite Dr. Alaa, the floor for you, Dr. Alaa, and you are welcome, all of you, inshallah.
السلام عليكم ورحمة الله وبركاته. شكرا جزيلا دكتور إبراهيم أخونا الكبير، والشكر مسبوق للدكتور عيسى أستاذنا الفاضل، الدكتور هشام أستاذنا كلنا، دكتور أحمد عتريس، وبقية الزملاء الأفاضل كلهم إن شاء الله. أتمنى إن شاء الله تكون يعني محاضرة طيبة، لأن الموضوع فيه كونتروفيرسي بين كل كلمة وبين كل استادي وبين كل جايد لاين موجودة، فنتمنى إن إحنا نوصل زي ما بنقول كده الأوبتيمال داياليسيس أو المور سيف داياليسيس قدر الإمكان يعني. Today we are discussing the cardiac arrhythmia and the sudden cardiac death in maintenance hemodialysis patient. On starting a lecture outline, the first part, the arrhythmia and the sudden cardiac death or sudden cardiac arrest. Second part, the hypoglycemia induced cardiac arrest. The third part, dialysate fluid composition and its relation to occurrence of sudden cardiac death, or how the dialysate can be modified to be avoid or prevent sudden cardiac death. The fourth part, it is a comparison between our Omani as part of GCC and the Japanese experience in dialysis. As the Japanese now, it is number one in dialysis outcome and treatment. Part 5 is significant studies that discussing about the dialysate or electrolyte imbalance or dyselectrolemia or dialysate related arrhythmia in specific. Cardiovascular disease is the leading cause of mortality in patients on maintenance hemodialysis. يعني number one preceding the infection and the malignancy, the cardiovascular complication. And the cardiovascular complication in chronic kidney disease patient occurring at any stage, from stage 1 up to stage 5. يعني it is progressing from the start. Sudden cardiac death is defined as an unexpected death from cardiac causes occurring within an hour or of symptom onset, or an unwitnessed death in patient known to have been well or very well or normal within the previous 24 hours. Sudden cardiac death account for approximately 25 up to 30% of all deaths in the hemodialysis patient. This lecture emphasizes the importance of identifying arrhythmia risk and preventing sudden cardiac death in vulnerable group. What about the epidemiology of hemodialysis? The epidemiology in hemodialysis, the prevalence of arrhythmia is significantly higher in dialysis patients compared to the general population. Sudden cardiac death incidence in dialysis patient range from 5 up to 7 per 100 patient years. Common in the first year of dialysis initiation, leading cause of cardiac death among end-stage renal disease about 30%, outpacing heart failure and myocardial infarction. Some variability exists across different ethnics and geographic regions. Hemodialysis schedule, what is most common اللي هو thrice per week or every other day or thrice schedule, and a long intradialytic interval. Long intradialytic interval اللي هي weekend days. Outside in Europe and USA, it is Sunday is the off day. In our Muslim region, we are the Friday. So we have patient doing Saturday, Monday, Wednesday, and the Friday off. The other group, Sunday, Tuesday, Thursday, and Friday off. In Europe, the opposite. For not in statement. A number of epidemiological studies have demonstrated that sudden cardiac death events, as well as mortality and hospitalization, occur more frequently on the first day following the long intradialytic gap. Monday, among patients on Monday, Wednesday, Friday schedule versus Tuesday among patients on Tuesday, Thursday, Saturday schedule especially. So it is occur in our countries. Friday is the off day, occurring in Saturday for who do Saturday, Monday, Wednesday, and occurring in Sunday in the opposite group who do Sunday, Tuesday, and Thursday. Why the higher risk? It is because long intradialytic interval. It is maybe reaching about 68 hours, and 1 day extra. On that dialysis, before the initiation of dialysis, a risk of sudden cardiac arrest increased by 3-fold. After 12 hours of dialysis, increase the risk of sudden cardiac death by 1.7-fold. So it is the most common or more prevalent in 20 hours before dialysis. Why the higher risk? Due to arrhythmogenic electrolyte imbalance, particularly potassium, because long time leading to more fluid overload and specifically hyperkalemia. So 12 hours before dialysis, the most cause or most common cause or the cause that we are facing is hyperkalemia. After 12 hours of dialysis, it is hypokalemia. In comparison to hyperkalemia, it is less. If we are seeing on the right to the schedule, we found that the difference between the two groups of dialysis and the prevalent, where the long intradialytic interval is still not corrected, be higher hospitalization during and after the long interdialytic gap. So if we can avoid this long interdialytic gap, we can avoid this risk of sudden cardiac arrest, especially due to hyperkalemia of the long time. Clinical presentation. Most of the condition occurring as asymptomatic or present with vague symptoms such as palpitation and dizziness, lightheadedness, or syncope. And syncope and the pre-syncope stage is most important. Sometimes may be transient and easily overlooked, necessitating proactive monitoring. Monitoring strategies: we do routine 12-lead ECG to detect baseline abnormality and the KT prolongation for our hemodialysis patient. Ambulatory Holter monitoring for capturing intermittent or silent arrhythmia. Implantable loop record, ILR, beneficial in high-risk patient for continued long-term monitoring. Wearable technologies, emerging tools that may provide time monitoring and arrhythmia detection, ongoing research exploring their role in this population. We can do it or insert it as a prophylactic or for primary and secondary prevention. This is still doubtful. Pathophysiology and the mechanism. Here we see that there is arrhythmogenic heart. يعني many factor can causing arrhythmia in normal heart or diseased heart. Normal heart or healthy heart, no ischemia, no arrhythmia, no myocardial infarction, no myocardial fibrosis and disease. Well, healthy, it is free. What is the arrhythmogenic heart? Anemia causing anemic heart failure, arrhythmia, congestive heart failure, and left ventricular dysfunction may be the most common leading cause. Left ventricle hypertrophy, left ventricle fibrosis, uremia, uremic cardiomyopathy is more common in our patient. Autonomic dysregulation or sympathetic overactivity occurring in chronic kidney disease, especially diabetic chronic kidney disease. Chronic kidney disease, mineral bone disease, also fluid overload is the most also arrhythmogenic effect on the heart. Dialysate, using low dialysate, LWB2, low calcium, can increase the arrhythmogenesis or arrhythmogenic risk, twofold increase in sudden death for patient dialyzed with a potassium bath less than 2 milliequivalent per liter. High fluid removal, more than 5.7% of post-dialytic weight. It is exceeding the tolerance of the patient of the refilling and making the patient more and more prone to arrhythmia. Treatment time, less than 3.5 hours. It is low efficient dialysis or inefficient dialysis. On the long run, is a patient complaining chronic volume overload, chronic electrolyte imbalance, and disease, both of them arrhythmogenic and leading to cardiac arrest. Trigger event because all this dilemma, in short, electrolyte flux, or in more specific, rapid electrolyte flux. Fluid shift, more specific, rapid fluid shift, myocardial ischemia, and lastly, we are facing dialysis-induced hemodynamic stress. All this causing the heart more strain or overloaded arrhythmogenic heart, leading to cardiac arrhythmia, and finally, sudden cardiac death. Common arrhythmia in hemodialysis, what is in the red line is the more common prevalent. Atrial fibrillation, ventricular fibrillation, most common, more than 70% of cases, either VT or VF. Bradyarrhythmia, since node dysfunction or atriovenous block or arteriovenous. Intradialytic arrhythmia, arrhythmia during or immediately after post-dialysis due to electrolyte imbalance. Risk factors for arrhythmia and sudden cardiac death. There is risk for arrhythmia on all population. General population, non-dialysis chronic kidney disease patient, or our last patient in the stage requiring dialysis or maintenance dialysis. General population, male 6, male more than female, coronary artery disease, left ventricular ejection fraction less than 40% or less than 35% is the most risk or dangerous risk factor. Personal and the family history of arrhythmogenic condition, congenital, either cardiac or vascular defect, periconjugal drug abuse, and the pro-arrhythmogenic medication. In non-dialysis chronic kidney disease, all the previous, all like general population risk, plus increased sympathetic activity, or we call it sympathetic overactivity, chronic inflammation, activated RAS system, vascular calcification, endothelial dysfunction, and increased end stage requiring dialysis or maintenance patient on dialysis, all the previous plus fluid and electrolyte shift, interdialytic hypotensive episodes, especially recurrent or chronic episodes, myocardial stunning, long interdiatic interval. What about the prevention and the management? Dealing with sudden cardiac death or sudden cardiac arrest, the prevention is number one. Yani our hope and our aim and our work is how to prevent it, not how to manage it. Yani prevention is more and more better than managing arrhythmia after occurrence. Number one, identify and treat the underlying cause, like control blood pressure, controlling blood cholesterol, correct electrolyte imbalance, especially potassium والمغنيسيوم والكالسيوم, avoid triggers like اللي هو increasing stress او increasing CNS activity like الكافيين, الكحول, النيكوتين and certain medication. Number two, dialysis modification, optimize dialysate potassium to be in average 3.5 not more. يعني maybe 3 is the best. Maintenance calcium at 2.5 up to 3 milli equivalent per liter. Adjusted dialysate temperature to prevent autonomic imbalance. يعني using low dialysate temperature 0.5 degree percent below the core blood body temperature is better. يعني 30 maximum 35 centigrade better than 35 to avoid any autonomic imbalance in the body. Gentle and slow ultrafiltration to avoid hypotension. Number three, pharmacological intervention, meaning the drug use that we are using the anti-arrhythmic drug like the beta blocker and the anti-arrhythmic drug like the amiodarone and the metafenone. RAS inhibitor for correction remodeling of the heart. يعني RAS inhibitor working important play in the cardiac or myocardial effective and prevention remodeling or stunning occurring. Number four, device therapy اللي هي implantable cardioverter defibrillator ICD and use the pacemaker for bradyarrhythmia. What does an ICD do? They do monitoring of the heart rhythm all over 24 hours for 7 days, continue track electrical activity to detect dangerous arrhythmia early, even before it is maybe completely occurrence. Deliver therapy when needed by SD, anti-tachycardia, defibrillation, shock, and backup basic. Rule of ICD in primary prevention in hemodialysis patient. Use of ICDs for primary prevention in end-stage renal disease patient remain controversial. Traditional indication for ICD in the general population used in patient low ejection fraction below 35% are less predictive in dialysis. Less predictive in dialysis patient due to the complex pathophysiology of sudden cardiac death in this group. Studies suggest that sudden cardiac death in dialysis patient is often due to bradyarrhythmia or asystole, the most common. So rather than VTAC and the ventricular fibrillation, reducing the potential benefit of ICD. Higher complication rate like infection and lead to more complication are noted in end-stage renal disease population using the ICDs. Thus far, no benefit to prophylactic ICD placement in dialysis patient. But even in normal population without dialysis, she can be reduce the risk by 30%. Hypoglycemia and the blood glucose. Hypoglycemia during dialysis isn't just a number on a glucose meter. It can trigger a cascade of physiological stress, especially in patients with end-stage renal disease. Why glucose fall during the dialysis? Number one, glucose diffusion. If the dialysate contains little or no glucose, a concentration gradient form pulling glucose from the blood into the dialysate, especially with zero glucose. insulin retention or accumulation. The dialysis can reduce insulin clearance, prolong its action, and lower glucose level. Meal timing: patient often fast before or during dialysis, reducing glucose input. Impaired gluconeogenesis or impaired renal gluconeogenesis. The kidney compromise not help produce glucose in this situation, but this function is compromised in end-stage renal disease. So the renal gluconeogenesis, formation glucose by the kidney, is compromised. يعني it is reduced or يعني not sufficient as a counter-regulatory mechanism. What is the impact of hypoglycemia in the heart? Hypoglycemia can do sympathoadrenal activation, endothelial dysfunction, vasoconstriction, KT prolongation, enhancement of inflammation, and increased thrombogenesis. All of them leading to myocardial ischemia and myocard or cardiac arrhythmia. And finally, sudden cardiovascular death or sudden cardiac death. What studies show? In 2025 review found that while direct causation is rare, يعني hypoglycemia is rare to cause arrhythmia or sudden cardiac death. Hypoglycemia may trigger lethal arrhythmia or seizure and can lead to arrest. Another study noted that hypoglycemia-induced sympathetic activation can destabilize the cardiac rhythm, especially in patients pre-existing heart disease. In another study in 2021, using continuous glucose monitoring, found that even with dialysate containing 100 to 150 milligram per deciliter glucose, sensor glucose level dropped below dialysate glucose in 50% of patients. About 25 experience asymptomatic hypoglycemia during or after dialysis. Another review noted that glucose loss through the dialysis membrane is a key contributor to hypoglycemia, especially when glucose-free dialysate is used. The lowest point in glucose level often occur towards the end of dialysis, the last hour or the last 30 minutes of dialysis session, when glucose stores are depleted and the insulin action persists. The last cause, but not written, is the diffusion of glucose into the RBCs. This also lowering the level of glucose. What about the prevention? Use glucose containing dialysate. Most centers now use dialysate within 100 to up to 150 milligram per deciliter glucose to minimize glucose loss. Avoid glucose-free solution unless it is clinically indicated. It is restricted to few cases like persistent or severe hyperglycemia. For some center prefer to 80 or 90 up to 100 milligram per deciliter and not going to 150. Number two, ensure nutritional intake before or during dialysis. Encourage a small carbohydrate rich small snacks before or during treatment. Avoid fasting before dialysis unless medically indicated. Adjust diabetes medication. Reduce insulin doses on dialysis days, especially long-acting type. Avoid sulfonylureas and other agents, which most of them high hypoglycemic risk. Coordinate medication timing with dialysis session. يعني try to prepare or taking the hemodialysis time best for the patient. يعني not just the patient eating as they start dialysis or eating since a long time and starting dialysis. Number four, monitor glucose closely. Check blood glucose before, during, and after dialysis. We are doing this routinely in our dialysis. If the patient diabetic, we may be more and more like this, like more frequent for blood testing. Use continuous glucose monitoring if available to detect asymptomatic drop in blood glucose, and this يعني is the best. but maybe more difficult for continuous glucose monitoring. So repeated blood glucose testing, more frequent in diabetic patient. Number 5, educated patient and the staff, train dialysis staff to recognize and treat hypoglycemia promptly and early by close observation of the patient, talking to the patient, observing that the patient may be some sweating, there is some more calm than before, or not respond to do the talk. So for early detection for hypoglycemia, for rapid and early correction. Teach the patient to report symptoms like dizziness, sweating, or confusion, even if mild. We are talking to the patient regularly by the staff, asking him like, are you okay? Any sweating, any dizziness, have any some lightheadedness like this. Number 6, individualized care plan. Consider comorbidities, nutritional status, and dialysis duration. Use risk prediction tool to identify high-risk patients. For example, those with low albumin or prior hypotension, these patients are more liable for complication, either arrhythmia or severe drop in the blood pressure. So close observation of them. And the more personalization of the dialysis to fit patient. One size, not fit all. So every patient is a number by itself. Number 7, have a hypoglycemic protocol in place. Follow up the rule of 15 in hypoglycemia. This means 15 grams of fast-acting glucose reaching and the rapid check for RBS or blood glucose level within 15 minutes. Keep glucose tablet or juice really available in the dialysis unit. All RMU are having this facility. They have some fridge, some have some juice, some sugar, some sweets like this for this rapid correction for hypoglycemia. What is the difference between diabetic and non-diabetic? Diabetic patient, baseline cardiac risk already higher due to either autonomic neuropathy already in the diabetic, ischemic heart disease, even in the early stage of chronic kidney disease. Before we are telling that a patient with cardiac problem or cardiovascular complication occurring at any stage of chronic kidney disease from stage 1 up to stage 5, but more prevalent for stage 4 and stage 5. Non-diabetic patients have a lower baseline cardiac risk compared to diabetic and less liable for complications than diabetic. Arrhythmia risk on dialysis significantly higher in diabetic, especially with glucose-free dialysis due to autonomic instability. In non-diabetic patient present this arrhythmia liability present, but lower than diabetic. Non-diabetic can occur if other risk factors coexist, like electrolyte shift, like hypotension. Hypoglycemia-induced arrhythmia, more prone due to impaired hypoglycemia awareness of the patient and the presence of autonomic dysfunction. The non-diabetic patient, this common, but can occur with prolonged hypoglycemia. And if the hypoglycemia missed for some time or long time, she can be more fatal even for non-diabetic patient. Sudden cardiac death risk is higher in diabetic compared than non-diabetic. KT prolongation susceptibility, it is more frequent in diabetic compared than non-diabetic. Electrolyte shift sensitivity, higher vulnerability to potassium, hyperkalemia, calcium shift causing arrhythmia. And non-diabetic less vulnerable. Rule of glucose enriched dialysate in diabetic patient strongly recommended to reduce hypoglycemia and arrhythmia associated with hypoglycemia. The non-diabetic may be used, but not always essential. So better to use normal glycemic, not high glucose dialysate. Protective monitoring require close glucose, potassium, and ECG monitoring during dialysis. Better patient with diabetic or have more liable for arrhythmia to put in monitor all over the session. Standard monitoring is sufficient unless other risk in non-diabetic. If have some arrhythmia, some attack, hypertensive ischemic heart, so we need close monitoring. If don't have comorbidities, maybe do dialysis without close monitoring. Recommended dialysate composition in diabetic, glucose enriched dialysate is must. Careful potassium and the calcium level. In non-diabetic patient, we can produce standard composition unless specific risks are present. Glycemic control
Sorry,
of
Dr. Alaa,
diabetic
for
patient.
interruption. Sorry for interruption. Can you make it speed up the lecture slightly for time? Speed up.
Inshallah. I will inshallah. I will tell you close in short inshallah. Glycemic control of diabetic patient on hemodialysis. Dialysate, use of glucose-free dialysate increase the risk of hypoglycemia, so should be avoided. Hypoglycemia might occur during hemodialysis treatment with 5.55 millimole per liter glucose containing dialysate. No clear consensus exists on the use of hyperglycemic dialysate, 11.1 millimole per liter glucose, but may be used in some USA or in Japan. Anti-diabetic medication, metformin is contraindicated. Caution with use with bensulfonide and meglitide. Insulin dose reduction may be required due to reduced renal insulin clearance. SGLT2 inhibitor is still not tested in dialysis population. Hemodialysis induced hyperglycemia, the other side of the mirror. Self-monitoring of blood glucose level may help to detect hidden hyperglycemia after hemodialysis treatment. This we call it like syndrome, or it is paradoxical hyperglycemia after death. Removal of plasma insulin by the dialyzer can lead to hyperglycemia in diabetic patient and reduce beta cell function. The occurrence of hypoglycemia during hemodialysis induce secretion of counter-regulatory hormone like growth hormone, which can lead to hyperglycemia after the treatment session. Blood glucose level should be decreased to 11.1 millimole before hemodialysis to minimize fluctuation during the treatment. If you have patient have severe hyperglycemia, better to reduce the blood glucose to near 11 or 10 millimole per liter before starting the diet to avoid the wide fluctuation of glucose during the diet. Assessment of glycemic control. Low and high hemoglobin HbA1c level are associated with increased mortality in patients with end-stage renal disease. Hemoglobin A1c level may not reflect precise glycemic control in patients on dialysis. Glycated albumin may be more accurate, but it is less used. What about the dialysate? The dialysate fluid, as all of known definitions, the fluid used in hemodialysis to remove the waste product and correct the electrolyte imbalance. Its composition, rule of dialysate, yani composition seen in the fact. In Oman, we use dextrose fixed 100 milligram per deciliter, and potassium fixed on 3. We have only one stable. Rule of dialysate, facilitate diffusion of solute and electrolyte across the dialysis membrane, help maintain and restore electrolyte and the acid-base balance, modulate the cardiovascular response by controlling sodium, calcium, potassium gradient, play a role in preventing or precipitating arrhythmia through its composition. This is our aim, the composition of our dialysate modulated to avoid arrhythmia. Act as a medium for temperature regulation, affecting the outcome stability. Customization. One size fit all, not anymore. Every person is an individualized by himself. Dialysate composition must be tailored to the individual patient clinical profile. Factor influence customization include baseline serum electrolyte, cardiac abnormality, diabetes status, and intradialytic blood pressure trend. What our types? We have 3 types of the buffering system: acetate, bicarbonate, citrate. Acetate not used. The bicarbonate is the most common. Citrate is the future. There is relation for arrhythmia. Acetate may increase the arrhythmia. The bicarbonate lower risk than the acetate. The citrate potentially lower the anti-arrhythmic burden. and the citrate have anticoagulant effect also. البنفيت from using البيكارب in dialysate في acute benefit and this is a long term benefit. All of us knowing that using low bicarb, medium bicarb, and high bicarb use. According to electrolyte composition, regarding the sodium, we have low sodium dialysate less than 138, high sodium dialysate more than 140, the potassium low dialysate less than 2, the high dialysate more than 3, the calcium low less than 2.5, the high dialysate calcium more than 3. The magnesium low magnesium dialysate less than 0.5, high magnesium dialysate more than 1. According to glucose content, glucose concentration في zero glucose وفي الجلوكوز enriched اللي هو التيبيكال 5 to 5.5 millimole per liter. What is in red اللي هو الاوكالت silent hypoglycemia. It is more common in glucose free or zero glucose. It is rare glucose enriched. To use more glucose content اللي هو الميديum, it is with our rule to avoid الhypoglycemia induced arrhythmia. Zero glucose or very low glucose more arrhythmogenic. According to the water used, في pure water and ultra pure water. In Oman we are using like international اللي هو ultra pure water. That is content less than 0.03 EUG milli per international studies اللي هو الانdotoxin to avoid inflammation and the chronic inflammation and the arrhythmia. Here we are comparison Oman with the top, what we call Japan, regarding number one in dialysis. In Oman, the average age mostly younger than patient under 65 years. In Japan, more older patient, maybe more than 70 years. Dialysis type mainly conventional in Oman, high hemodialization. In Japan, use advanced online hemodiafiltration. Here in Oman, using hemodiafiltration, but in Japan, this is a standard use. Dialyzer type, we are using the standard type in Oman. In Japan, all using the high flux or super high flux dialyzer used widely. Dialysis dose, KTV, variable in Oman. Some patients get inadequate, and 1.2 is accepted, 1.3, but in Japan maybe reach 1.7 KTV. Annual mortality rate, data not well reported like higher in Oman, around 5 to 10% annual mortality on the best globally in Japan. 5-year survival rate, unknown on our data, not sufficient in Oman, higher than many countries. It is 33% better than the USA itself. Here, why Japan outcome are better, longer dialysis session, more than 4 hours. High use of online hemodiafiltration, strict water quality standard, personalized dialysate composition, and lower prevalence of diabetic in Japan. Here we're comparing Oman with Japan and USA. We found that the comparison, we are not far on higher from other. You see, we are following the international rule. Long session, ultra pure dialysate, low comorbidities burden. USA shorter session, higher catheter use compared to Japan, more AVF use. In Japan, more than 76% of the patient having AVF. In Oman, AVF use may be 70 up to 73% of Omani hemodialysis patients are having AVF. Longer session, we're doing it in Oman, not allowed below than 4 hours. Experiment intrafracture of hemodialysis. What about Oman in the strengths and our facing the challenge? Fully government funded dialysis for citizens, all citizens having the facility for free dialysis. The challenge limited kidney transplantation within Oman, but now we are growing and going on our program. High AV fistula usage above global average. challenge rising in the stage burden due to diabetic and hypertension, still worldwide rising for end-stage renal disease. Expanding nephrology workforce and infrastructure. The challenge is need for more personalized dialysis rate protocol and ultra pure water system. Now we're using nearly ultra pure water system, and the quality of water reaching the more than reaching the standard of ultra pure. What about our 2024 Think Kidney Symposium and their recommendation? Emphasizing on the vascular calcification prevention with good control of hyperphosphatemia and dealing with peritoneal dialysis program going efficiently and expanding now in Oman. Discussion on non-steroidal mineralocorticoid alpha-neuron receptor antagonist and their role in chronic kidney management. And you will focus on the kidney transplantation and organ donation. Quality of life improvement protocol tailored to dialysis patient in Oman, inspired by global best practice and role in locally. I will read only the lines to not extend the time for our colleague.
Please, we have 5 minutes. Try to finalize, please.
Right. Inshallah. Symptom-based assessment, like why symptom like fatigue are strong predictor of mortality and hospitalization on Omani patient, or often more so than lab result. Enter the realistic exercise program. We are starting here in the SIB with Dr. Ahmed Atris, and you are hoping to extend to all the RMU that the patient not like bedridden in the bed or the session. We do try to do exercise and increase the physical fitness of the patient. Nutrition and the lifestyle counseling. We are going this for the patient. Monthly dietitian visit, focusing on the protein energy balance, phosphate control, and the hydration to avoid the protein energy wasting or protein energy malnutrition. Psychophysical and emotional support. We are having all our unit having psychological and emotional support to our patient, because most of our dialysis patient complaining from depression and anxiety. We try to improve the mood of them by changing the lifestyle of the patient, by helping to overcome not feeling that he's handicapped and like this. Patient empowerment and education, dialysis goal and symptom, medication side effect, transplant option and process. Monitoring and evaluation, close monitoring and evaluation for the patient to make good adherent or more adherent to the dialysis number thrice per week, and the dialysis population at least 4 hours or reaching for 5.30 hours. What about the studies? I will go in short, rapid. The Hemo study 2002 in English Medical Journal, and it is a type large randomized controlled trial, number 1,846, population predominantly using hemodialysis USA patient. It's A arm standard versus high dialysate 2. We're comparing KTV 1.25 compared to 1.65. Low flux versus high flux membrane, and the primary outcome regarding all cause mortality, the key on the cardiovascular finding. Second study, the ADOPS study, ongoing since 1995. It is have many phases: phase 1, phase 2, phase 3, phase 4. Type is a prospective or observational study, more than 12 countries. It is including the GCC and including Oman also. The focus, dialysis practice variation and outcome, and the key cardiovascular disease insight. Longer dialysis session duration more than or equal 4 hours is associated with reduce the cardiovascular mortality and morbidity, improve volume control, reducing left ventricular strain and left ventricular ejection fraction failure. Number 3, MAS study 2017, it is in Jason, type prospective with continue ECG monitoring on population hemodialysis patient with cardiovascular risk. Other study, MBPO study 2009 in Jason, similar to HEMO study but done in England. Pivotal trial 2019 in comparing the protective effect of proactive iron versus reactive iron. Number 3 ال FHN trial 2010 in gym compared اللي هو daily dialysis 6 session per week compared to conventional or traditional thrice per week. Any question? I reach the end.
Thank you very much, Dr. Alaa, for this presentation, which is full of more knowledge and information regarding sudden cardiac death. Now we open the floor for questions. But before that, we invite Dr. Hisham Said or Dr. Sassal for any comment regarding this subject. Dr. Hisham, Dr. Isa.
Thank you very much, Dr. Alaa. It's very comprehensive, very informative. I believe that it's a very good text. I wonder that we have to share on all the groups, just the texting, how a lot of data inside, and importantly to read carefully for a better outcome. For sure, you tackled many points, and I like the differences between Japan, although the demographic parameters from Japanese and the natural cardiovascular disease is different from all over the world. But I would like, if you allowed me, just to highlight one of the very important topics, may explain some of the importance. For example, in Japan, they are using glycated hemoglobin as a parameters of death or mortality, and they are from 2012 maybe or earlier that glycated hemoglobin should not exceed 20% of the albumin. So it's an important, very important parameters. Second point, in Japan, they are using higher pre-dialysis magnesium. All over the world, they are saying that patient on dialysis should start with higher serum magnesium than in normal, 2.5, like 2.5. That improve because magnesium move by diffusion, so hypomagnesemia is inevitable in all patients on dialysis. So the starting dialysis approaching magnesium 3. They have pros and cons on that for sure. For higher magnesium, it doesn't improve the CKD, menopause and the vascular calcification, but it improves the cardiovascular stability. So they are using more pre-dialysis approaching 3 or 3.2 magnesium, which is quite high. And higher magnesium dialysate all over the world is 0.5 millimole. They upgrading the dialysate magnesium. I would like to thank you again for the QT interval, because it's one of the major cause of sudden cardiac death, especially you highlight exactly in patients with diabetes. And importantly, to just announce for our colleagues and juniors for their drug-associated QT interval, in particular quinolones, zithromycins, and all of these medications should be taken cautiously in patients, in particularly who are prone for QT interval. My last comment for the Japanese style of dialysis. All over the world, they are fear of albumin loss. However, in Japan, they permit albumin loss up to 3 to 4 grams. And they have a rationale on that, because albumin renewal is more importantly because albumin and glycated albumin is a toxic material. So they permit 3 to 4 gram loss of albumin during dialysis against all other the world. I would like to thank you again, and really I enjoyed, and I will be very thankful if you can just share the text as a PDF to distribute to all our colleagues. Thank you very much.
Thank you, Dr. Hisham. Okay, thank you. Dr. Isa, any comments?
First of all, I'd like to thank Alaa for excellent lecture, and Dr. Hisham Said, of course, for the comment. And I would agree. The big demography between Oman and Japan is quite clear. In fact, the studies showed that Japan is not only better than Oman, better than even European United States, despite their elderly age. And despite they use, in fact, if I remember correctly, LOPI, as stated by Alaa, is the actual continuous hemodiafiltration, and of course the healthy lifestyle of Japanese, which contradicted to what we are doing in our part of the world. but excellent lecture. Thank you, Alaa.
Thank you, Dr. Thank you.
We have some questions and some welcoming from Dr. Ahmed Atris on behalf of Professor Dr. Isa Salmi to all attendees, especially Professor Sham Said. Another comment also from Dr. Ahmed Atris regarding the diabetic patients. Please avoid to start hemodialysis session with random blood sugar less than 7 to avoid hypoglycemia and arrhythmia. Yes. Other questions from our colleague Dr. Asada. What about the obstructive sleep apnea and the risk association with bradyarrhythmia in dialysis patient? I think this is one of the common missing risk factors, sudden cardiac death in hemodialysis patient with our attention. What's your comment, Dr. Alaa, regarding this point?
Comment obstructive sleep apnea.
Yes.
Well, obstructive sleep apnea now considered one of the most risk factor causing many dilemma in the chronic kidney disease or dialysis patient. And this can consider one of the causes or the leading or helping or pro-arrhythmogenic for our patient. And our patient is vulnerable to many complications. Obstructive sleep apnea now there is some stress on it, and it is maybe causing some problem in the oxygenation and the other radical that found or accumulated already in chronic kidney disease or dialysis population. Maybe also one of the causes leading to arrhythmia in this subgroup, especially in our group, are vulnerable to more and more the complication, like cell anemia, and can causing the anemic heart failure and the sudden cardiac death in this population. That what I know, but I think obstructive sleep apnea now, need more thorough investigation and need more investigation, especially in our dialysis population.
Okay, thank you very much. Especially obstructive sleep apnea is more common in our dialysis patients. Majority
Yes.
of them, they have this issue, but that's why very important questions. Dr. Abdul Halim, there is recommendation to check glucose before dialysis to all diabetic patients. Is it recommended to screen all patients before dialysis?
All dialysis population are recommending to check blood glucose, and as our routine here in Oman or in my RMU, you are at the beginning of the dialysis, we testing or checking all the vital in the trial, including the RBS at the count, either the patient diabetic or non-diabetic. In non-diabetic, we are testing him routinely at least 3 times, at the starting of the dialysis, at the mid of the dialysis, even we are testing it at the end of the dialysis to avoid any fluctuation or changes in the blood glucose that is maybe hidden and avoid the hypoglycemia. A diabetic patient more and more close also routinely. If we are using testing blood glucose in patient non-diabetic 3 times, the diabetic patient may reach 5 times. To check and confirm it by glucometer, and sometimes we are sending another sample to the lab also. Now we have in our review that we have now a blood gas machine. Now this facilitate to even check electrolyte or RBS or anything that in the media every hour for patient. So I think even stabilized patient, normal patient, have the diabetic and having any comorbidity, at least we test the blood glucose level for him at the beginning or before starting dialysis.
Dr. Abdul Halim added also another question about the target glycosylated hemoglobin for hemodialysis. If there is any specific target?
Target glycosylated hemoglobin in diabetic patient in our dialysis population, we try to fixing the hemoglobin A1C at the level 7 to 7.5. I think it is what we called him mild hemoglobin, mild glucose control for him, not strict or very tight glucose control. It's the best for our dialysis from hemoglobin A1C from 7 to 0.75. Below 7 is not accepted, not good. Over 8, it is not good. I think the better level recommended 7 up to 7.5.
But Dr. Ahmed Aris added information regarding there is no recommendation from any guidelines to trace the A1C in dialysis patient. Sometimes they are giving bizarre results.
هو bizarre because the life span of the RBCs and diffusion.
Yeah.
So glycosylated hemoglobin A1C,
Yes, of course.
yeah, not the accurate one. And even in our dialysis population, the reading that it come usually often يعني below the target level or below the normal exactly level. So glycated albumin is more and more accurate for measuring blood glucose, but it is less used in our يعني labs and our countries like this. يعني. Maybe like Dr. Hisham saying that in Japan, depending on it. So in Japan, it is more and more accurate of testing the blood glucose during dialysis than our country.
Oh, if you allow me just to
Yes, of
comment
course.
on these 2 points, I will come from the end for the hemoglobin A1C. Yes, exactly. There is no recommendations. Even the latest guidelines from endocrinology saying that it's a fragile patient, so they put all in the same basket between 7 and 8. And Ahmed Atris exactly saying that there is no target hemoglobin A1C for patient on dialysis, but it's a fragile patient, so it's between 7 and 8. And false low and false high hemoglobin A1C is recorded in patient. I would like to come back to a very excellent comment from Dr. Saja for the obstructive sleep apnea. Yes, it's very common, up to 30% of our patients.
Yes.
What's very risky for those patients even, the CO2 generation during dialysis is from bicarbonate dialysis. So there is a lot of CO2 generations that pass the dialyzer membrane to the patient. And if there is any kind of hypoventilation, there will be CO2 retention. So patient with sleep apnea syndrome or obstructive apnea syndrome, in general, hypoventilation, hypercapnic, will be at more risk of CO2 retention during the dialysis therapy. So we have to think about that, and I would like to thank Dr. Saja for highlighting this very important point.
To add to this, majority of our patients, they are maintaining on CPAP. They are coming even with their device during dialysis.
Yes,
CPAP.
yes.
Yes, exactly. Because dialysis-induced hypoxemia, yes, is well-known phenomenon, but CO2 transfer during hemodialysis is an additional cofactor for respiratory depression.
Yes, Dr. Saja, she's willing to add something?
Yeah, Assalamu alaikum. Thank
Wa
you for
alaikum
the
assalam.
discussion and thank you, Dr. Alaa, for the excellent presentation and very fruitful discussion. Actually, I highlight this issue because it can be prevented, because you can use like the positive pressure ventilation for them and prevent this bradyarrhythmia associated with obstructive sleep apnea. It's just to be highlighted. It is like quite common, maybe 1/3 of the patient, and in some literature, it is reported up to 60% of the hemodialysis population they have, or peritoneal dialysis, they have some evidence of obstructive sleep apnea.
That's right. That's right. Any other comments or questions from the audience?
دكتور ابراهيم also يعني a non-diabetic patient maybe have episodes of hypoglycemia during session, and
Yes.
we should search about the cause,
You are right.
especially if the symptoms of hypoglycemia occur. يعني we have interesting case in our hospital, and the patient usually have episodes of hypoglycemia during session, and we doing the workup, and still in the workup, and maybe the patient have insulinoma.
But that's why Dr. Alaa highlight the issue of individualization of the session.
Yes.
We should يعني adjust الهيمودايليسيس session individually from patient to patient. We are not putting the same protocol for all. يعني. That's right. Okay. Any other questions? Any comments? طيب دكتور أحمد عزيز can you close the session please؟
جزاكم الله خيرا جميعا، وبالغ الشكر لأستاذنا الدكتور هشام السيد والزملاء من الخليج، الدكتورة رولا والدكتورة فاطمة والزملاء الآخرين. وسبحانك اللهم وبحمدك، نشهد أن لا إله إلا أنت، نستغفرك ونتوب إليك. بسم الله الرحمن الرحيم. والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. شكرا جزيلا.
شكرا جزيلا، نشوفكم على خير دايما يا رب.
شكرا
شكرا جزيلا
على
هشام.
شكرا
دكتور هشام.
هشام.
شكرا.
شكرا مع السلامة.
دكتور أحمد سوري، في اجتماع للجمعية ولا خلاص كده فاينلايز؟
هو بروف عيسى معانا. بروف عيسى، حضرتك تحب ان نكمل اجتماع للجمعيه؟
ايوه، في ايشوز احاول ايوه طبعا.
حاضر.
other people
اوكي
الله ماشي.
حاضر. يبقى الزملاء بس في البورد ينتظروا، ما حدش يخرج من البورد.